Um, we, as many of you know, have had ICD-10 trainings throughout September, and I wanted to have this time to kind of like connect with everyone and see what you're experiencing and what you, if you had any questions. And I wanted to share with you what we as a billing company have been finding. Um, just a couple housekeeping uh, notes to start with is on the right side of your panel. Mine comes up on the right side. There's a gray control panel. I think you can move it if you want to, but there is a place for you to put questions in. And if you want to speak and talk as well, if you let me know that, I can unmute you and let you be able to talk as well if you would rather do that than type questions. So I want to get going. Um, we started, we bill every single day. So we started literally billing ICD-10. I did some on October 1st. I was just chomping at the bit to get some myself personally and called clinics and said, if there's any you can give me, I want to see what happens with the clearinghouse, the payers, etc. So I started personally, and there's a number of us here that started immediately sending claims on October 1st. And what we found out is there were many, many payers. I was so shocked that started to pay within 3 to 4 days. Blue Cross is really a fast payer. We're in Minnesota, and I know that this varies by state and payer and everything, but in our state, Blue Cross is really fast. And so I think I had a check within 3 days of sending the claims. And then about mid-October, I started thinking, oh no, I haven't seen anything come through with Medicare. And Medicare had some glitch with NGS and different carriers they had where their checks didn't drop properly either. And so then I started thinking, oh no, it's been almost 3 weeks. We haven't gotten a Medicare check. And then I remembered they have a holding time. They literally have, they don't have to pay for 21 days. And so then I kind of calmed down, and I actually saw my first Medicare check or payment on the 19th for an ICD-10 claim. And since then, really everything has been really uneventful. I haven't worked comp and auto. They had talked about possibly they weren't ready to accept ICD-10s. I haven't done anything personally but bill ICD-10s to every single payer. I haven't received one back stating that they couldn't accept ICD-10 codes. The mandate for ICD-10 comes under the code sets of HIPAA, and auto and work comp aren't covered under HIPAA. So that's why, that was kind of an unknown factor, but CMS had issued them a notice that they're no longer maintaining ICD-9 and really warning them they better, get up to date and use ICD-10, and that appears to have worked. So that's really, it's kind of a non-eventful time for us, but I want to see what you're experiencing. So I'm going to open it up and see if you have questions or if you want to share what you're experiencing. Upcoming, we have a few webinars coming, just so you know. One is how does a billing service work? There's no charge for that. Another one, what really makes a practice successful in bringing better cash flow is to define good, solid follow-up policies and really break those down by contract, non-contract, and self-pay. And we're going to have a webinar on that to increase your cash flow. And then one area we've seen that a lot of providers aren't aware that there's an OIG compliancy issue on uniform charging practices, and actually we would like to have a webinar and put out there for everyone the rules and regulations, just like we did with our ICD-10, what's the backbone of the presentations we do is we always give you the law, we give you the facts, we don't give you our opinion of it. And so we will do that whenever possible, whenever there's anything possible governing the issue at hand. So let me see if anyone has questions. I've got one from Michael. Let me see if I can open his question up here. I'm having a bit of a trouble here just opening it up. Just bear with me 1 minute. One moment. I'll be back momentarily. I had with Michael, I had answered previously. I am back, and the question I'd had with Michael, I had answered previously, so that's why I could not open it. I can unmute everyone. I don't know if anyone would like to share what their experience is. If you want to discuss anything, or if you have any other questions. But from our perspective, we really don't have, there isn't any issues. I have got to say, I've gotten 2 clinics in the last 2 days who are afraid of billing ICD-10 and haven't billed anything since October 1st. Or maybe I don't know why that is, if they hadn't gone to trainings or whatever they had. So we've got that going out there. But of the things we have sent, everything's solid, getting paid. The other thing that could be an anomaly from our state to your state is that the state of Minnesota, and I think there's 4 or 5 different states across the country that require electronic claims. And by doing so, I've seen providers give us invalid ICD-10s, but those don't get through. We can't enter them into the software. That we get a flag there first that it's invalid, and then we get a flag in the upfront edits. And then if it were to somehow get through the back end edits with the payers, they would notify us too. So maybe just the mandate of having electronic billing in Minnesota has really helped us too, because of the edits. We can't send invalid. Now you could of course send wrong, like there's the accident, the sprain strain codes that you have A for active, D for maintenance, and S for sequela. As long as it was a valid code, and it could happen in any arena, you could send the wrong code and not get it edited. But I haven't had that problem. The other issue is there is the possibility that the unspecified codes that are going through now, and I've seen quite a few of those where the doctors don't say if it's right or left or which part of the spinal column it is, if they do the unspecified. There is the possibility that those codes are going to get denied, for sure within 12 months and possibly sooner. So um, I don't have anything else, and I maybe have a question here from. It looks like I do have a question from Jen. I'm just needing to find it. Just one second. I apologize for the confusion. For some reason, it is not popping up. If you could, in the bottom of your screen, there's a chat button. If you could type there, I'm going to send you all a message now. Please ask your questions in this area. I just sent a message to everyone, the entire audience. If anyone out there could just kind of like answer back and say got it, so I just know that you can see what I typed. Okay, good. I see Jordan got it. So that's good. So if anyone there on the line would want to share with us their experience or ask a question, that would be great. I'd really appreciate it. Here's what Jen asked. Malaysia M79.1 versus myositis unspecified for M. At one of my seminars they attended, they recommended not to use the Algia diagnosis and why. And here's where my foundation goes completely back to the rules of billing. And as soon as I get someone that says that, something in that effect, I immediately go to the government policies and say, well, this is down. I can open it up on a different site, just a second. And I immediately look at, well, what is Medicare's guidance? Because they're, again, the godfather. You're probably sick of me saying that. But they are, and they have established rigorous rules for medical necessity. So if there's something that you shouldn't be doing, you're going to find that in Medicare's guidelines. So I'm just scrolling through the policy right now and trying to find the codes Jen had mentioned. And first, just to review, your Medicare for medical necessity for a chiropractic treatment to be covered requires the first diagnosis to be from the Group 1 codes, and that these in our state are the only 5 allowed. Minnesota varies greatly from Florida, I recently found out. So you might want to look at your states. Yours might allow more, but in our state, these are the 5 available to us. And then after we pick one of these for the area that we're going to adjust, then the second thing we need to do is figure out the symptom that is driving the patient, to come see us, and it should correspond. Maybe it's headaches if we did cervical or whatever. If they mismatch, like say you have a cervical region and the symptom code 2 is low back pain, they'll kick it out, because to meet medical necessity guidelines, you have to have an area that has a subluxation, and the same area is triggering a symptom or one of these covered diagnosis And so they need to match. And then before I move on, third and fourth, always fill with your subluxations to support your number of treatments. So the codes that we have at hand, that Jen question is, let me just scroll up here, M79.1 and M79.1 and M60.9. So let's see what Medicare tells us about that. Is this something that they would allow? I'll stop with 60.9 first if that is on here. Okay, so 60.9 isn't on here, and 79.1 is not what they would consider Medicare being a covered symptom to meet medical necessity guidelines. I am just going to open, we have a tool that we use called Supercoder that is available. You can have a subscription to it, and it's a really good tool that coordinates entirely with Medicare in its guidelines. And so you still got the backbone of medical necessity being put out there. So let's see, I'm just going to put first code Jen put down was M79.1. And see any kind of alerts that we get. We know already it's not covered under Medicare. That's a big alert that you might not be able to cover it. You might not meet medical necessity. Now, here's the tricky part you really should realize is we go to training and auditors talk to us all the time, and some of them are very dramatic. I had one named Jackie that when people would ask, well, how do you get this? You know, if someone comes in for myalgia, how do you get that covered? And we all would like myalgia to be covered, you know, but what in a purist form, what we're here to do is identify the problem that the patient is having and the treatment needed for that problem. And lastly is the payer source. You know, so if this, for example, was a Medicare patient and this was truly their diagnosis, you would still want to treat them. And you wouldn't want to say, well, let's pick something else that we think is close. Because if this was really their primary reason for presenting, you need to stick with that. And Medicare is doing tricky things. We found where they send letters to patients and get their side of what they thought they had done and why they had it done. And so in this case, myalgia, you know, if that's not covered, and it isn't, we just looked at it, but that's the real reason for being there, then what we do is we issue something called an advanced beneficiary notice to the patient. And I'm just going to bring one up and show you how to fill it out. And tell them that your treatment will help them, and you're much better than I would be at defining the intricacies of chiropractic treatment. But in this case, Medicare doesn't recognize it, just like they don't recognize dentures, they don't pay, hearing aids, they don't pay. There's a lot of things that are needed that they don't pay, but they won't pay for myalgia. So in that case, you would give them this advanced beneficiary notice and say, if Medicare doesn't pay for, in D here, you would put down treatment, CMT, chiropractic, however you wanted to put it, chiropractic manipulation therapy, CMT, treatment for myalgia, because it's not covered under their medical necessity policy. You're going to charge, $30 a visit. And then the trick here, and this is the big trick, is they have to pick one of these boxes. A lot of times I've seen clinics just throw out the policy and said, here, sign at the bottom. Well, it doesn't mean anything because they didn't pick something. Plus, I'll see where they throw it out and it's not completed. Well, they're not agreeing to anything either if it's not completed. So, they either want yes, they want Medicare billed, they want the service in D, and they want Medicare billed, and you would put a GA modifier on that, telling Medicare that you've notified the patient of non-coverage and they've agreed to pay for it. Or they might say too, no, I want the services listed in D, but I don't want to bill Medicare. And where this really benefits you is, and we're going to cover this in our charging practices webinar, is, you really can't give a cash discount, or a time of service is the proper way of saying it, discount to a patient and bill Medicare and wait for it. So if the patient wanted to take advantage of that discount, and you can do that under certain circumstances, and they want to pay today, then the only way would be for them to take option 2. Or maybe option 3, they'll say, I just don't think I'm going to get treatment then, and they'll put that, choose that. And you know what? It would cover your butt, I don't know a better way of saying it, to have this sign, even if they choose not to get services, because you can prove that you did an informational session, you explained, the Medicare guidelines, you as a Medicare contracted provider are living up to your expectations. And through that, you can, put this in the patient's chart. If Medicare ever says, well, I heard you refuse treatment, or whatever the deal is, you've got this document to help you out with that. So that was a good question, Jen. Thank you. Thank you for sharing. And the answer is go back to Medicare's LCD. That's always the answer. Can you use M99.00, Michael asked, for a headache? And that goes back to the same thing. Let's see if it meets medical necessity according to Medicare's guidelines. M99, we got a lot of 99s in here. Nope, M99 isn't listed as a covered code for your symptom code with Medicare. Now, here's the other thing that we're going to review when we do our webinar on developing policies for follow-up for different payer plans, is there is also, everyone on the call today has a couple different buckets. They have those buckets where you have signed a contract with a insurance company. You physically can go to your file cabinet and find that contract, and you have agreed to do certain things like bill on behalf of the patient, not to bill for the patient for anything but insurance and deductible, things like that. In those cases, you really need to follow your guidelines. Now if the question was, can you bill the M99 code for Aetna, and you don't have a contract with Aetna, well, certainly. I mean, what you're really doing when you're billing those non-contracts is you're doing courtesy billing. And the patient has a contract with Aetna, but you don't. And you, as a courtesy to the patient, are just sending that claim, forwarding that claim along. I want to look up one thing with M99 before I go to my next question here. See what guidance we have here. So the long description, segmental somatic dysfunction of head region, refers to impairment. Here's one thought, and you all there on the call are doctors, I'm not. And so what happens with this medical necessity is they're wanting to, as part of you writing your treatment plan, they want you to be able to demonstrate that you can make this person better, incrementally better. You write out in your treatment plan what your goals and guidelines are. in with things with myalgia, maybe that you can't get better. Maybe there isn't, that it is a maintenance disease, that the best you can do is not get worse. And that's maybe why those are excluded from the coverage guidelines, because it's been identified as a ongoing long-term symptom that isn't going to increase. And these words in here are making dysfunction. I'm just questioning if you could write a treatment plan and expect improvement with this symptom. Just a thought when you're looking at stuff, but that's maybe why it's not on Medicare's policy. Okay, so the next question, oh, I'm sorry, I put the wrong one in. It's M99.10. Let me put that in better. M99.10, and I'll go back to the policy too, because that's what is so important from coverage guidelines. And the other thing I have found, 99.10 isn't there either, is the big payers, they call the government payers, they're Medicare, Medicaid, Blue Cross. And, Blue Cross works for a lot of private companies, so I always was confused why they called that the government payers. But they do the federal employee programs. They do many of the VA government, TRICARE, Champus, all those programs. So they're considered really governmental insurance, and they really have strict medical necessity guidelines. So the M99.10 is not there. And again, let's see. This is subluxation. Oh, this is the subluxation part. So we would go back to the core, what covers they would pay. Let me go back to my policy. So I know it's not in there, but here's the thought process. So here's what's covered. And I've been told by doctors, again, I'm not a doctor, but I've been told that adjusting like the sacral, or not the sacral, the neck area, which would be the 10, is considered an extremity. And so they're only going to adjust the spinal column. That's the only thing the Medicare has agreed to adjust. Now, that being said, I could go right to Florida's policy, and they cover 98942. So they do cover extremities. And so I would guess if we go look at their policy, there's a good likelihood M99.10 is in there. So you really want to go to your policies for your company, your state. And I'm just going to show you one more time here how to do that. The CMS.gov, of course, Centers for Medicare and Medicaid Services, is where we want to go. And if you type this, just type interactive map, it drops down, it remembers. Then it'll open up, and when it gets here, this directory where you can actually click on this map and then click on your state, and it will bring you to, I'm just going to do Florida so you can just see. I was so intrigued. I've done chiropractic billing for 21 years and have never seen 98943 covered. This Part B here, that's what chiropractic services are covered under for outpatient. And we want to say they always want us to do a test. I'm going to put Florida in, and we're going to put Part B. And we're going to go to LCDs, local coverage determinations. This acceptance is kind of interesting. The AMA owns the CPT codes. That's why you're always getting this. I feel that we're all really fortunate that the World Health Organization owns the ICD-10 codes, because there was no charges for books and materials and things like that. You could really get a lot of items available. search by a code. I'm just going to put a procedure code in, 98940. Each state looks a little bit different, but they really have the same terminology of what you're looking for. And here's our policy. I'm just going to keep going down. So here, first of all, is where they say the covered HCPCS code. This one, 98943, isn't covered. And then here's our code 1. This is what they want for the first code. And it has and it's only for the 404142. And then if we keep going, sorry for the scrolling, kind of makes you dizzy, I know. There's sure a lot more. This policy is a lot more loose as far as what's covered than what Minnesota is. What I'm looking for is code 2. Here's your sprains, strains, anything with an S is your accidents, and those are still allowed with Medicare if you have one that's within your policy. And then it has what doesn't support, and it doesn't have anything. So it really doesn't have the same structure mandate that in Minnesota and maybe in your state would have, where these are the only 5 codes that you can put first, and then these second ones have to be related. So it still doesn't have that same structure. But here's the part that you should really, as a doctor, just nail on, just hone in on, and really make sure your notes, it tells you step by step, if you were ever audited, this is what they're going to look for. And they're going to look on your initial visit, they're going to look in your notes that you have this, and it's going to go through, I'm sure, your subsequent visits. Here's your treatment plan, what they want. There's going to be a part exam in here too, but they give you exactly what Medicare think you as a doctor need to while you're contracted, you're obligated to do that. And if you really adopted that policy and did everybody the same, it would really make your notes solid. And so if you ever were reviewed, it would have everything you needed, that you followed their plan. You did it, Okay, let's see if I have anything else. It says, I bought a crosswalk for $100, listed it as being upper cervical specific. We have used it a lot. Okay, Michael, tell me what state you're in, and I can look that up too for you. And there's one more question. Is your suggestion that one should stick closely to Medicare's diagnosis when dealing with private insurance? Yes, because it's not that it's Medicare's diagnosis. I mean, it is, but the principle is they're really sticklers on what meets medical necessity guidelines for an insurance to cover it. And that runs throughout the fields. Some people, like I do billing for a plastic surgeon, for example, totally unrelated. But if somebody has a breast reduction, they or breast, whatever they're having, lift or whatever, insurance will pay for it. If it meets the medical necessity guidelines, if they have enough tissue that needs to be removed that can be causing strain on their back, then they will pay for it. And so if you know what those guidelines are, I'm not suggesting that you change them or make them meet them. I think our goal is to figure out, okay, this is what the patient's presenting. This is what the patient needs to have done. and then look at those that you're contractually obligated. Is this covered under them? Now, just because it's not covered doesn't mean it's not warranted. You know, many people with this plastic surgeon have had breast reductions that don't meet the guidelines. There isn't enough tissue, but there as a person aren't comfortable enough. They would be so much happier with smaller breasts. And so as you're looking at this, what should we bill and use for guidelines? Medicare is a kind of a good cheat sheet. If you look at it and say, okay, myalgia is not covered, that's good indication it's not going to be covered under other payers as well. And, you know, this is something that you could, the ABN, incorporate in your office and say to the patients, you know, this is what we find that the payers suggest is covered under medical necessity guidelines. Many of our patients have benefited from services not covered under guidelines, but we want to, you know, make you aware that this may not be covered by your insurance. And you know, what a better way as a patient, when, you know, I would want that, if I would want someone to just be upfront and say, you know, myalgia is something that's, you know, really, we can really treat, but we can't improve drastically, and therefore Medicare doesn't, it's in a maintenance category. Medicare doesn't pay maintenance, or it's likely Blue Cross won't pay this because it's maintenance. But you can really benefit from this as a patient if you know, have a lot less pain or uncomfort, whatever your terms that would be that you'd give them. So that's kind of everything. I kind of get off on tangents, as you can tell, to try to hit all the points that I think might benefit you. And I think that's it. I don't have any more questions. I think I will sign off unless somebody wants me to cover their state LCD, or if you do, just put a question in and tell me what your state is, and I can look that up. Okay. Okay, I have a Missouri. I have a per question regarding Missouri. This is good. I haven't seen Missouri's LCD. So here's Missouri. And looks like WPS is your carrier. And here's the different areas that we could go through. Your contracting, home health, let me just see, railroad. Okay, so it must be this top, WPS Medicare. We had WPS in Minnesota until two years ago. It accept. Okay, and then once we're here, provider enrollment, active policies. And we want the local coverage determination. I just want to see one other thing here. So I just wanted to look at the shape of the... Okay, so here's all the different things we could look up. And we have chiropractic services for Missouri. And I'm going to accept the AMA. We're not going to sell their codes. And then this starts the LCD. And I'm just going to scroll till I find. It starts out just giving you, they all do how you can treat. Like some states don't allow you to do adjustments through anything but manual. You can't use certain equipment. Some do let you. Talks about the part when the patient comes in and you need to do that rather than the x-rays that changed in 2000. Here's the documentation you need to put for your subsequent treatment. in your treatment plan, what necessity for treatment. And then this one gives your levels of subluxation that would be covered. And so the occiput, that was what I was trying to think with 0.10, but see how they have an extra one, the 0.00 in Missouri that we didn't have in Minnesota. And then it goes through the treatment parameters. And then we start with the covered codes. Notice Minnesota and Missouri are the same. Florida has that extra 98943, the extremity. And then we're launched into code 1. And again, as they're listed here, Missouri covers one more code than Minnesota. And then we're go into code 2. And I'm just going to go down just for the heck of it and look at the codes Jin gave us. M60.9. And just see if that's in there. M60 no, and M79 no. So those must be something like long-term. Like, for example, mental health is another one. They won't pay for Alzheimer treatment because they know, that you have to, in your treatment plan, demonstrate that they're going to get better or show improvement, and then you can't. So yeah, so that's not going to be covered, the myalgia. So let's see if I have anything else. St. Louis, if that helps. Missouri, I'm glad you put that in there. The jurisdictions, they're called, that govern each state, governs the whole state. So if you can bill that way in one area in Missouri, you can bill that way in St. Louis. They're all the same. Missouri is Missouri. Do we have any more questions before I sign off? Okay, so I am going to sign off, but before I do that, coming next week, we're going to have a webinar on how do billing services work and interact with providers. And then coming up in the next 2 to 3 weeks, we're going to have a webinar on how to practice, how practices can create follow-up policies, and through that get better cash flow. And some of the things we touched on today demonstrate exactly that, because you can get a feel for, first, to see if there's meeting medical necessity. Next, look at what your contractual obligations are, because you might even have a contract with an HMO that has you fill out a separate form different than the ABN. And then third, a big thing we hit on is the non-contracts. How do we manage those when you don't have a contract and you're just doing courtesy billing and you may not get paid? And then after that, the next 2 or 3 weeks after that, we're going to have a uniform billing practice webinar to go through how OIG wants providers to charge uniformly to all payers, whether it's insurance or patient. And there's laws out there that I'm going to give everyone that tells you what you must do to be compliant with that, so you don't get into trouble with discounting, say, cash for patients and not discounting insurance companies, and then they view you as discriminating against them. But there is ways to do it still, just to do it and be compliant. All right. Well, thank you so much for sharing Halloween and your Saturday with us. I really appreciate your time, your questions. It's been a good session. You have a great day. Thank you.